This is a second session of our fifth international conference, whose theme is mitigating the post-COVID-19 impact on the realization of sustainable development goals. And at this point, we have our guest speaker ready. And our guest speaker at this point is Professor Hama Rogo. Professor Hama Rogo will be making a presentation under sub-theme 1, Universal Health Care, SDG 3, Good Health and Well-being. Participants who are online, we request you to log in, and when you will need to speak, you raise up your hand, and or you will unmute, and then you will be permitted at the right time. Meanwhile, you maintain, those online, you maintain your mics muted until you are permitted to speak. So at this point, I have my colleague Opole. Where is Opole? Mr. Opole is the rapporteur.
Present online.
We are also ready, and we also, I guess, the presenter, our guest speaker, professor, is also ready. It's online, and we will give him 30 minutes to make his presentation uninterrupted. And then later on, those with questions, comments, clarifications you want to make, will give you time during plenary. So may I then therefore, chair of the session, request that Professor Hama Rogo makes his presentation. Professor, welcome.
Thank you very much. Let me check if you can all hear me. Can you? Can
Yes,
I be heard?
We can hear you.
If you can hear me, then I start by thanking the organizers for making it possible for me to have a chat with this distinguished audience. I say so because I value education, I value academia, and I value the exchange of knowledge. I am doing this from my village in Siaya, where I am quietly and comfortably retired. And I hope that I will be inspired by the village spirit. You asked me to address the topic of universal health care, a topic that is close to my heart, and probably the only topic that I can say I know well. Universal health care is a term that was coined fairly recently, but its origin is actually much older. It is defined as a concept or idea of everyone in a country or in an area accessing healthcare without fear of cost. I'm going to simplify health and all these definitions to the level where you don't have to be a clinical health person. So everyone accessing care without fear of cost. Remember that right now, even where you sit, there'll be some of you who have some niggling concerns about the eye, the nose, the ear, or even the toe. But you've not been to any clinic or consulted anybody, because the first thing you ask yourself is, how much time will you spend there? How much money will you spend there? And have you budgeted for it? So that fear of cost is a major impediment to the healthcare seeking behavior that we desire. WHO tries to define universal healthcare along 3 points, which I will refer to as the legs of the African stool. It's made up of access, that's one leg of the stool. It's made up of quality, and it's made up of cost. And that the 3 must be there together for universal healthcare to be realized. Just like the African stool will not be able to stand if you amputate one of them. So access, quality, and cost. So it goes further to emphasize that it's not just a question of accessing healthcare without fear of cost, but accessing appropriate quality of healthcare. And we will ask ourselves what that is. In the developed world, countries that are richer than us, the only country that stands out not to be able up to this stage to give universal health care or coverage has been the United States of America. And this has been the genesis of what many of you will have heard referred to as Obamacare, because during his time as president, that son of Kenya tried to introduce care for everybody in the United States. But you can see the problem that is had, because people, as simple as it might and reasonable as it might be, not everybody wants everybody else to get care. Not everybody wants everybody else to get the same level of care that they do. That's selfishness. And that is why if today, if you filled the parking area of the Nairobi hospital with people who have walked on foot from the muddy streets of Kibera, police would be called in, tear gas would be thrown, and there would be total chaos. Because the people who go to Nairobi hospital don't want to be treated in the same place with the barefoot people from Kibera. This is why if you go to Kenyatta National Hospital across the road, you will find that you will meet everybody, barefoot and the ones who are just flown in. And you will see the crowds that are in there. So access, quality, and cost are so interrelated that you can't separate them. But then in that case, I'm trying to define universal health care. But I must remind you that the key issue here is health. And define it the way that it does it. What does it say? It is the complete well-being in terms of physical, mental, and even spiritual. It is not the mere absence of disease. So you are not well when you are not healthy simply because there's no disease, but you are healthy because all your systems are working. Imagine our primary schools today, ladies and gentlemen, where there is a child who is in standard 4, has been given a seat at the back of the class, but that child is short-sighted. Every time the teacher writes something on the board, poor kid doesn't see anything. But the teacher keeps asking him to read what he has written in capital. And the poor boy can't read because he can't see. But the teacher doesn't know that. So at the end of the year, end of the day, at the end of that class, fellow kids laugh at him or her because they think she's very stupid. But all that she has is a problem with seeing. If there was universal health care, all those kids would have had an age and a regular intervals, their eyes. We would see the ones therefore see very far, and we would put them in the front row rather. I'm giving you an example of this because you don't have to be sick to the point where you're vomiting for you not to be considered to be a health concern. So universal health care then is that. And our country, being part of the United Nations system, we adopted the agreed to implement UHC in Kenya. And you will see that in the big four of our president, UHC is considered one of those. And this is not by accident, because even in the DGs and in the MDGs, I'm assuming you have all those acronyms with you, Millennium Development Goals and the other development goals. Health has been central there. Without being biased and without apology, I must say that health is everything. Ladies and gentlemen, health is everything. If you were given the choice to be rich or to be healthy, I would choose to be healthy. A lot of Kenyans would choose to be rich. But let me tell you, you cannot enjoy your riches when you have some boil somewhere in your bottom. You may buy the biggest sofa set, but you'll not be able to sit comfortably. You will not enjoy it. So health is everything. But the argument that health must be at the center of development has previously been defeated by economists who say it is the economy that must be at the center of everything. And we were, in a way, relieved when COVID came, because all of a sudden we found that disease could actually stop the economy. All economic activities will stop. Cabinet meetings will stop. The hugging and greeting will stop. The president will not be able to inspect the guard of honor, and so on. The army can't even sit in the barracks. They can't go fighting because of just one virus. This is not the first time it's happening in Africa. Ebola, when it hit Guinea, Sierra Leone, and Liberia, completely did a coup d'etat, a disease coup d'etat. Because when you stop a government from talking to you and addressing you, you basically have overcome the government. So please take health seriously. Without health, nothing will happen. None of those professors will teach you. None of those students will attend to the lecture. So that is the background that makes UHC such an thing. But then let us remember something, that universal health coverage, when you want to give it to everybody, it is not that easy. One would have thought that it would be extremely easy. Like, for example, if you want to feed the hungry and you give them food, they should gobble it. How come when people are unhealthy, health, they don't appreciate? The reason is very, very simple. That not everybody is unwell at the same time, not at the same frequency, not with the same intensity. People who are not well tend to understate or underappreciate good health. You don't know how useful good health is until you are unhealthy. You don't know that until you are unhealthy. So whenever we try to say health should be for everybody, those of us who are well at that particular time, because it is only temporary. There's nobody who goes from birth to death without being sick. Stop feeling that they are being burdened by the poor health of other people, the poor health of other regions, the poor health of other countries. This is where the global debate is. But those who can afford or who have access, always making difficult for people who cannot afford or who have no access. The usual humanity selfishness. This is why health is considered to be human right. That is why in our constitution, the 2010 one, access to healthcare is considered to be right. It is not a privilege given there. So if you were to go the UHC way, the question here is, are there pros and are there cons? For the universal healthcare approach, there are certain very, very compelling reasons why we must go for it wholeheartedly. And I hope that by the end of this talk, each one of you will be an advocate. Number one, if you go the UHC way, it costs less to the economy. It is so expensive when people are sick. And when you have more people sick than the people are producing, every sick person stops producing. So this is the cheapest way. So if you're talking about economic growth, health is wealth. Health is wealth. Two, that the administrative costs when you do it universally are much lower than the administrative cost of doing it as we are doing it now, where it is by chance. So look at the cost of the economy and the administrative costs. Number three, it is simpler to organize the UHC process so that everybody knows their place, where they can go to care, predictability of the cost of that care, and so on. So we are all getting something that's uniform, not based on whether you have a title of engineer or doctor. So it is simpler process. Number three, it actually strengthens the health workforce, a very, very important component of building health systems. And you've seen in our country, the labor unrest, that's there, the nurses, laboratory people, doctors, clinical officers, everybody is going on strike. Everybody is complaining that they are overworked, even when they are underworked. Everybody wants to be paid more because there is no uniform measure of the quantum of work that you're doing and the expectations in terms of your output. When we have an organized UHC, then that becomes easier because you start being able to objectively pay people according to their output rather than just their qualification. And then, more important for UHC is that it favors the vulnerable. Ladies and gentlemen, we are not equal in the space of health. We may be equal in the eyes of God, but in the eyes of a virus or a bacteria, we are not equal. There are some people who are more vulnerable to being sick because they are poor, because of their geographical location, or because of certain things that they're born with are deficient. Those people are more likely to get good coverage without fear of cost when we have UHC. Women and children are the biggest users of health systems, and they are also the most vulnerable because they are facing disease for the first time when they are born, or their immunity is reduced. Under UHC, women and children who would be vulnerable, elderly would all be covered, not only the strong youth who sadly fall sick. So remember those things, that there are reasons for it. But let's also remember that there are some challenges that it brings. And what are those challenges? The challenges is that when we have an arrangement of UHC, everybody must pay, not only the sick, not only the vulnerable. And everybody must pay according to their means. And I'll go into that a little bit more. And that's where people have a problem, because somebody who is extremely rich, some of our millionaires, wants to pay the same, for example, NHIF rate as somebody who's earning 10,000 shillings. That's not, they must pay more because they can afford to pay. So that brings in some of the fractures that we are having in this argument. Two is that for some reason, when people are covered, they take it for granted and they drop individual responsibility. I'll put it to you that health is not given to you by the Ministry of Health. It is you who maintains the health that God gave you and brought you to this world. Throw it away and we shall struggle to give it back. If you refuse to take it, there is nothing we can do. It worries me when, for example, right now in the COVID epidemic, we have out all the public health guidelines on what should be done. The mask, like the big one that I have here, the washing of hands, and keeping distances, which I hope wherever you are right now, you. And yet, even the most educated doesn't do that. Then when they get COVID and they are breathless in an ICU, they ask, where is the government? The government is not a ventilator. The government is enabling you to know what you must do. So that individual responsibility sometimes is thrown out of the window because people know that when I'm sick, I will be able to go to the clinic and not have to pay for anything. So that is an important issue of individual responsibility. The other thing that happens in UFC, which is a challenge, is that it may start reducing the individual income of health workers. So, for example, the consultants in Nairobi also can charge an egg and a lamp, an arm and a leg. If we had good universal health care, you would be able to go to any health facility that would give you the same level of care. And you would be guaranteed how much you pay because your national insurance would have negotiated the cost for you. So that tends to reduce the amount of money that individual entrepreneurial doctors may earn. And they resent that. And that's why you may see some of them arguing on the other side. I'll give you an example. Did you know that the health outcomes, that is the impact of intervention in Cuba, which is a country which is as poor as us, is way better than the United States next door, which is the richest country in the world. So it's not about how rich a country is. It is about how organized. Now UHC compliant is for them to be able to do that. UHC sometimes could also slow technological innovations and introduction of new technology. Although actually, new technology should be more embraced because if it makes the delivery faster, more universal and cheaper, it should be. But in some instances, people who find making profit more important than making health tend not to want to adopt UHC. Then there is also the challenge of budgeting. UHC requires expert budgeting, not just people who put money there and take it. Budgeting skills are required. We don't have it in our ministries of health at the moment. This budget that was read the other day, interpreting it into actual health delivery is a skill that not many of us have, and not that the people in leadership usually want that is there. Let me put it this way. The delivery of health is very, very easy and very simple for so long as the ministries of health do what the ministry is supposed to do, which is deliver health. The moment it deviates into other things, then it becomes complex. And I'll give you an example. The biggest game in a lot of our ministries of health in the developing world, in Africa, and even here in Kenya, has not been the delivery of health, it has been procurement. Everybody is interested in health because it is one of the biggest public procurement areas outside the military and roads and infrastructure. That's why cancer is such a big problem. Have you ever asked yourself why we can't cure cancer? We can cure cancer. It's simple, because the game at cancer is not about providing health, but procurement. Who gets the contract? How much do you make out of it? How rich you are at the end of it? That is challenged by this concept. UHC may also have a challenge in terms of limiting services. So, for example, you've seen people are in NHIF, they give you a package of what they cover. They can't cover everything. but they give you a package. So you are careful in terms of how you claim this particular package. That can be limiting to people, especially people who are extremely rich, who can fly out of this country and go to Dubai and stay in a place that's more expensive than the Kempinski, just because they feel tired. Those people have a problem when you start rationing healthcare, which UHC. And then, of course, for UHC to work, it is a challenge of how there is inter-system and intersectoral collaboration. Health is not delivered by the health sector alone. Education sector must deliver. Water and sanitation must deliver. Infrastructure, roads and so on must deliver. Industry must deliver because manufacturing of medicine is there. So the functionality and coordination between the sectors. Now let's go to how. How would you deliver UHC? I go back historically that we were colonies once, colonies of the French, colonies of the Portuguese, English, and colonies of anybody who wanted, even the Arabs. And what we inherited at independence was essentially health systems that were akin to what those colonizers had in their country, albeit a poor version of it. So here in Kenya, we had a district health system, which was the British. All over the Commonwealth was the same thing. At independence, the war cry of our founding fathers was that when we get our independence, we shall defeat the three big enemies: disease, ignorance, and poverty. Of those three, I would put health to be on top, followed by equally ignorance and poverty. Because sick people, they can never get it. The rich will be made poor by ill health. Now, there's a break there. That while before independence, Queen Elizabeth did not have an obligation to provide health care for all of us. She never even knew us, all of us. When we took over, Jomo Kenyatta and subsequent governments had the responsibility of giving care to all of us. Unfortunately, we followed exactly the same system that Queen Elizabeth was leaving behind. That was never meant to deliver health to all of us. And there has been very, very little innovation outside. It's basically been tinkering here and there, but we never changed it. I'm so ashamed of us that 60 years later, we are still just thinking the same thing, which is not delivering, and we are not brave enough to be absolutely revolutionary. Now, how do we deliver that? From an economist and financial point of view, we have two systems. One we call the supply-driven system. This is what the British left for us, and this is what we are still trying to provide. And this system was that there is something called the government that builds some facilities called health center, clinics, and hospitals. And it keeps telling you that when you are sick, go there. You will find a doctor and nurse, medicine, X-ray, and everything. That promise, we tried it for over 50 years. Every time we went, either that clinic was not built and finished, or it was finished, but there was no doctor, or there was a doctor, but there is no nurse, or there was a doctor and a nurse, there was no medicine. And you had nowhere to complain. You simply walked back home with your disease and recovered, or if you had something in your pocket, you went to a nearby pharmacy or a private doctor to look at. So the lack of accountability is enormous. No wonder after the Second World War, the British changed from that and went to their National Health Scheme, Insurance Scheme, NHS, which has worked. We never did. So we blindly continued to use what these people have abandoned and expected it to work for us. Unquestionably, it has failed. So the supply system has failed Africa, Anglophone, Lusophone, and French. We are now moving into the second, which we call the demand-driven, demand-side. And this is where the NHIF or health insurance comes. This system, which is the one that has worked in all developed countries except the US, instead of promising you that when you go to the hospital, everything is there, it gives you an insurance card that says that go choose where you want to go. When you arrive there, get the care that you desire and deserve. After you've gotten it, pay through this card. In other words, the power is shifted from the facility to the user, to the patient. And these are monumental shifts, because for the first time then, that poor Mama Mboga will be able to walk to a clinic because she wants to be seen within 30 minutes, because she has to open a kiosk at 8. If you can see her, she will move to the next one and choose another one that complies with her lifestyle and with her desire. This is what the demand side financing creates. And this country, after a very undesirable and time-wasting piloting of UHC that you all noticed done here 2 years ago, we have now decided to be sane and say, hey, let's go through this demand side. Let us see how we can register everybody under a social health insurance scheme that we are calling NHIF. Let's run it well. Let us give people cards, because demand side financing is a contractual arrangement. Supply side is not a contractual arrangement. It is promissory. And there's a difference between a contract and a promise. So what we should be talking about is how do we contract with health providers so that they give us one form of care that is equivalent to the money that we have paid in NHIF. That is where we are right now, and that should be where the future is. So I appeal to you, ladies and gentlemen, that in your elevated levels of understanding, you start becoming advocates in this area. There is so much misconception, so much ill information about how to make health work in our countries, how to make UHC work. People see it as expensive. I say it is not. Expense is not the delivery. Expense is the inefficiencies and the corruption. And that one will fail you whether it is demand side and supply side. But it may be easier for us to detect and be more confident if we went on the demand side. Finally, the question is, where do you get health so that you become healthy and it is universal? First step is you. Health is in you and your behavior. When it is compliant, the rest of us become healthier. And it's not just you, the people around you too. So the individual, to the family unit, to the community. That's why NHIF does not register individuals, it registers households. It is the head of the household and the rest of the family. If all our households were compliant with COVID, we would have no need for lockdown. We would have no need for vaccines. We would have no need for the kind of begging that we are doing right now. Remember this, ladies and gentlemen, that COVID has come to us. Much as it is devastating, it is also a learning point for all of us. Number one, it has exposed our soft underbelly, the promissory kind of healthcare where the governor or a minister tells you, oh, we are ready, don't worry, we are that and that, oh, we have done that, we have medicine at cancer, we brought LPPEs. That is hogwash. Promissory healthcare doesn't work. It has to. How do we sue the minister when he says that he has got PPEs, but when we go to hospital, we don't find it? How do we sue the leadership when they say that HIV drugs are available, but they are not available? If it was contractual, you could sue them. If it is promissory, absolutely not. So that is the first thing, that it starts with you, it starts in the house. Secondly, it is about prevention, prevention, and prevention. Health is maintained when you prevent things that make you ill. Don't wait for the make you ill, because we do not know how your body will react. And that is what's happening with COVID. That if between me and you, we all got COVID at this minute, there is nobody who can predict which one of us will end up needing oxygen in an ICU and which one of us will be symptomless and walk there. It has nothing to do with my height, weight, or my social status. So it is prevention, prevention, and prevention. Without that, it doesn't work. Health facilities and hospitals come in late. They are what a garage is. The garage does not keep your car on the road if you keep knocking everybody, including pedestrians. The garage can help. But the garage is helpful when you go for service, so that you need it because there is no oil or water. So these facilities should be go for service, and they tell you that the systems are all okay, go back to work. If we do that, then we shall find that all these big hospitals, brick and mortar, that we spend so much money on, are unnecessary, that they are not utilized as much as they should be. Remember, right now, it's not in the interest of any politician to go to the next election claiming that, you know, I have been your MP for the last 5 years and I managed to defeat cholera by making you wash your hands and making you behave. It is earns more votes if you go there and say, I am your MP and I built sub-county hospitals and so many health centers. Even if they're just empty buildings that have nothing, but people vote because they've seen a building. The unforeseen things in health are the things that prevent healthcare. It is in this time, I want to summarize the following. Ladies and gentlemen, universal healthcare is easy to define and easy to do. We can do it, but we'll have to be more purposeful and we'll have to be more honest. The biggest driver of cost of healthcare in this country is not the private sector, it is the public sector, and it is the corruption that makes everything inefficient and expensive. So for you who are still students for management, procurement, law, and everything, we need you in this sector just as much as we need doctors and nurses. The day when we shall adopt honesty, trust, and prevention as our mantra, that will be the day that universal healthcare will begin to happen in our country. Yes, we can do it, but it must start with you individually, and it must start with you collective to be advocates of UHC. Thank you for listening to me. I have my mask here, which is protecting my bad teeth and my bad breath. I appreciate the audience. Thank you.
Thank you. Thank you very much, Professor Omar Rogo. for the wonderful presentation on universal health care. And Professor has ably made the point on universal health care with a rallying call that what constitutes of health, and he says prevention, prevention, prevention. That is the rallying call. Professor has also posted this, and which is very pertinent, that ordinarily, when asked whether you would prefer to be healthy or to be rich, and he has put that moral question there for all the participants to ponder over, whether you want to be rich or you want to be healthy. And he said, maybe some majority might want to become rich, but you can't eat if you are sick. So that is the moral question for all of us, the participants in this conference. His presentation revolved around 3 questions. One, touching on the historical perspective of the healthcare in Kenya since independence. And then the second question, and where his presentation revolved, was how do we deliver health? And where do you get health? That is, in summary, the presentation by Professor Robo Hammer. Thank you very much. I know participants online have questions lined up. They wish to get clarifications. But as I said at the beginning, we get the clarifications. We will want to allow that to come at the end during plenary. I want to thank the presenter because the other guest is ready online, and is ready. Our guest speaker, second guest speaker, Dr. Mumina Guyo Shibia, is ready online, and we wish that we get a presentation. After her presentation, then we will ask the participants to present their questions, or you write in the chat, and then the questions will be summarized by the secretariat, and the presenters will be, our guests will be able to respond appropriately. So colleagues, participants, may I now request that we prepare for this other presentation. The presentation is under sub-theme 2, Food and Nutrition Security, SDG 2, Zero Hunger, by Dr. Mumina Guyo Shibia, research scientist, Kenya Agricultural Livestock Research Organization, KALRO, and I think the presenter is ready to make the presentation. Welcome, Dr.
Thank you, Professor. Can I be heard loud and clear?
Loud and clear.
Okay, thank you so much. And I would like to request the IT team to allow me share my screen, please. In that process, the university board, the vice chancellor, academia, scientists, researchers, extension, if they are present, extensionists, farmers, pastoralists, all protocols observed. Ladies and gentlemen, good afternoon. And I'm so delighted to exchange knowledge with the young upcoming talents and skilled youths And also as well as our seniors who have been in this in the sector. Okay, I don't think if it will allow me, it's refusing to allow me share my screen. I'm having some challenges and still not allowing me to do that. I don't know why it's not allowing me from my side. Okay, let me see.
The technical team is in the process. They're trying to allow you in to share the screen. So just hold on a little bit. They're doing something.
Yeah, if it doesn't, and then I just kind of send the presentation to the mail, and then they can do the necessary as I speak to the with interest of time, you know, if just in case they're, yeah. I think that's what I'll do. As they do that, I'll just kind of send that at the interest of time.
Yes, please.
Yeah.
She's sending.
Yeah, I'm doing that. Yeah, I'm doing that, and in a short while, I'm sending to conference at Kibabii, so it's already gone. Please check on the other side. That way we can save some time. Yep. Received?
Try to present, we see.
Is it there, please?
Just try to share again. Yes, it's now co-host. You are now co-host, yeah. Try to share to present.
Okay.
Just try. Just try.
Okay, you can share, only host can share. Who can start sharing when someone else is sharing? Okay.
The green one. Share screen.
Yeah, I did it, but still not allowing me. It has refused completely.
Can we allow her just to present? Like the other
Yeah,
person?
I can speak.
Yes, please.
Yeah,
Carry on.
I
Just
can.
carry on. Carry on.
Yeah, I think that's what I'll do. If they find my presentation in the mail, then they would kind of they will pull it up. So in terms of the outline, ladies and gentlemen, I will have a brief introduction looking at the susceptibility, vulnerability, implications of COVID-19.
Yeah, you are
Okay,
now
I'm viewing Julia's
you are,
screen.
you are
That's
now
okay.
sharing. You are now sharing. Very
I'm
good.
now,
Yeah,
I'm not sharing.
you are sharing. It is now off again.
No, no, Chair, it is me. I was trying to share from my screen, but I wish
Julius, you
by-
can do that,
by-
please. Yeah,
You were sharing that time.
yeah, Julius, you're doing it.
Yes, I was doing it, but I don't have your presentation. I could have shared it.
In the email,
Let me check.
I sent the email to the conference at Kibabii, conference 21 at kibu.sc.ka just 3 minutes ago.
Can you check that? Yeah, they will still have given because.
Okay, let me talk as they pull out the presentation from the email. I think I'll continue speaking if they.
For moving.
Okay, let me continue with the presentation, and then as they fix those technical issues. So I'm going to look at the COVID-19 pandemic implication on food security and agricultural product value chain. So I'll be mainly focused on susceptibility, vulnerability, and implications of COVID-19 on food insecurity, availability, access, utilization, and stability. And then we have the implication on the agricultural input output value chain, and then what next in terms of building resilience. Agricultural sector globally contributes largely to the economy and livelihoods in the developing countries, with 80% of the world's poor living in the rural areas depending upon agriculture. And projection under pre-COVID-19 scenario was expected to feed 9.7 billion people by 2015 to provide opportunity to the poor working adults and reducing extreme poverty. The industry, which once accounted for 4% of the global GDP, the gross domestic product, in 2018 to 2019 is under stress of COVID-19 pandemic and other factors simultaneously. Agricultural value chain not only face slow, predictable change, but also rapid and predictable change. Prior focus have been predictable control, planned, managed change, with much less attention to the ability to face the unexpected, to navigate surprises, to benefit from unpredictable events. An adaptive cycle of thinking distinguishes between the long exploitation phase, characterized by slow, predictable, marginal change, and the shorter release phase, often after an unexpected shock, which is characterized by rapid and often transformational change. So we have the adaptive cycle of resilience thinking framework. If the technical team would be able to pull out that, that's fine. If not, but with the onset of COVID-19, it's a shock that really triggers the economy. It triggered the economy, and the food sector, other than just the health, went along and being affected with some kind of collapsing, causing some distraction, and some seeking for new opportunities, new connections, trying other configurations, reorganization, or what is working and what is not working. Some coming with exploitation, some growth because they took advantage of the opportunities, and then adaptation, and then gathering resources so that we can set back to stability where before or when COVID-19 did not strike the sector. It is always important to look at the COVID-19 impacts alongside other drivers of vulnerability and food insecurity. We have the food system, where we have the food production, land preparation, inputs and services, agronomy and management, harvesting. Then we have the food transformation, where we have the transport, storage and handling, processing, wholesaling and retailing, security, political economy, and climate and environment. Then on other end, we have food consumption, purchasing, and acquisition, where we have consumption and utilization. The focus is on zero hunger, that is SDG 2, end hunger, achieve food security, and improve nutrition and promote sustainable agriculture. And the SDG targets I would be focusing on. Okay, I can see. Thank you for helping me. I appreciate that. Okay, we can go to slide 6, please. Thank you so much. So as I indicated, is that we need to look comprehensively when we look about food security. The drivers, we have COVID-19, which is a driver, along with other drivers that are very important. But also we should not always just focus on the food production bit. We have the food transformation and the food consumption. And there are certain conditioning factors, because we are going to see them, that really affect the food sector and for us to achieve the SDG 2. Please, we go to the next slide. Slide number 7, thank you. So as I indicated earlier, we are interested for this section or session on the SDG goal number 2. And I would like each and every participant to look at your Google app or your app store, whichever software you have. You have an app on SDG that you can download and be tracking what is really happening globally. So that in terms of awareness, we create our own awareness. So that app is available. Please, at your own time, download, and then we follow. So under this SDG 2 of ending hunger, the first target is end hunger and ensure access by all people to safe, nutritious, and sufficient food all year round, including the poor, the vulnerable, and also the marginalized, and even the indigenous people. And the second target is end all forms of malnutrition. But depending on the country target, by 2025, we control stunting and wasting for under 5, meaning we've eradicated them. And then address nutritional needs of adolescents, girls, pregnant and lactating women, and the elderly, which are vulnerable. The next target is double agricultural productivity of small-scale producers. We know very well that majority of our producers, especially in developing countries, are small-scale producers. Ensure sustainable food production systems and implement resilient agricultural practices in terms of increased incomes and productivity. And by 2020, maintain the genetic diversity of seeds, cultivated plants, and farmed and domestic animals and their related wild species. Also importantly, increase investment in agriculture in terms of research, extension, infrastructure. And the other one is correct and prevent trade restrictions and distortions in the world agricultural markets. Lastly, but not the least, adopt measures to ensure proper functioning of food commodity markets and derivatives to facilitate timely access to market information. Take me to the next slide, please. Before pre-COVID-19, we already had enough issues in terms of food security. It was already on the rise from population affected moderately to severe food insecure, with an increase of like 2% globally. That's when you look at the numbers, that's big. Stunting and wasting among children are likely to worsen. And pre-COVID, we had already 144 million children under 5 stunted. And for wasting, we had 47 million children suffering from wasting. On the small scale producers, food producers are hit hard by crisis. By like 40 to 85% of all producers. And there are kind of so many shocks that's happening in the food system. We have the climate shocks, we have conflicts that are going on around the world, we had locust invasions, and then boom, COVID-19 came in. Next. What did COVID-19 did? What kind of interventions pulled us back? Lockdown, restrictions, health protocols, compliance. It really affected the agrarian and small-scale farming and remittance-based economy. It ravaged the economy. Business shutdowns, which creates the demand for food and even agricultural commodities. Job losses, dwindling employment opportunities, hard to find jobs, either in the private or the government sector. Youth unemployment hit hard, and age most affected, 15 to 24 years, and under 30, also in the informal sector. Getting a meal a day is a struggle, disrupting both national and global value chains. Looking at the input side to support production and productivity, and the output side to ensure you have food on your table, affordable, nutritious, and safe. Food production, marketing, distribution, and food safety was thrown into unbalance, and with the exacerbated unemployment and food security situation. Next. If you look at that pictorial, you see the first part, we have the farmers. And then we have the factories waiting to transform the raw materials from the farm into finished goods and taking it to the consumer on the table. And you could see ourselves, the population, lining up for food. The question is, how do we secure supply of agricultural commodity value chains under COVID-19 without interrupting, without prices changing, without quantities declining, because it has an impact, it has effects. Some of those commodities are not on the shelves, and the few that come in are exorbitantly very expensive. So the thing is, how do we ensure that supply continues with a shock that was unexpected? It has never happened in a long time, like 100 years, while most of us were not there. Next, please. What are the COVID-19 implications? Income distortions for farmers. Private sector companies less competitive and less positioned in the market. Remember, the government does not employ so much. What the government does is to facilitate the private sector to boom in terms of creating opportunities for employment. At this moment, you find those in private sector losing their jobs. What happened? Food security for a planet, for our own planet, under pressure for COVID-19 while we were dealing with all other shocks. Thus, COVID-19 just intensified vulnerabilities and inadequacies of global food system, and it might have pushed between 83 to 132 million extra people globally into chronic hunger in 2020, and it has not left us because some of the economies, we are not yet at par with other economies. Some economies are moving on, and our economies, we are not yet there. We still have issues that we are supposed to deal with. Still 149 million children under 5 are suffering from stunting. Remember, we are supposed to eradicate stunting by 2025. And these estimates might be even higher by like 15%. But in terms of stunting, we might come to see the impact in the long term, not necessarily so much at the short term. Next. Wasting, that is low weight for height, and overweight affected like 45 million people, with 39 million are children under 5. Also note, we were supposed to eradicate this by 2025. Could the world be able to reach there? So in terms of what is really causing this, deterioration in the household wealth and disruptions in the availability and affordability of nutritious food and essential nutrition services. The overweight, the children have not been going to school, they've not been exercising, they've been locked down with people. So the thing is, they're kind of very immobile. And also the food that are affordable to the household might not be that nutritious. Everyone is just trying to survive, to fill the stomach. Some even don't have something to fill in the stomach with. So unhealthy food replaces fresh, nutritious food, and movement restriction constrain opportunities for physical activity for long periods of time. In terms of labor productivity, it went down because you cannot have full capacity working in the factories, working even in the institutions, whether it is academia, in research, in extension, all these were distorted. And I would like us to take note of the July 2020 updates for under the SDG from the UN, and they will be able to give us the kind of a concrete COVID-19 impacts, especially on SDG goal number 2. So the surge in the number of acutely food insecure during COVID-19, as you could see the graph, those in IPC 3 or above are kind of increasing over time. After 2017, we kind of made some strides, and then 2018, we came down. 2019, we took off. 2020, by 20 million, we've already done. That is even before COVID. Now with the COVID, it is predicted that this number is kind of double, which is stand at 270 million food insecure people globally. And that's the global goal of achieving zero hunger by 2020 seem increasingly out of reach if we don't do enough to reverse it and remain on course. Next. Implications on the agribusiness value chains. We already kind of highlight or kind of raised in my earlier slides, but remember, looking at the agribusiness value chains, they're kind of interlinked with so many actors. This is an output value chain mapper, kind of a prototype. You find the suppliers, transporters, processors, packages, operational services, financial services. These are all kind of a support system, technological development, research, regulatory bodies. And everyone was affected. Each and every institution was affected in terms of environmental forces, technological forces, social-cultural forces, and then we have the direct actors who already the links was so weak. And then we have the economic forces, we have the legal and political forces. So with all this, we couldn't move much as expected that we were supposed to move. So these linkages were already weak. So what COVID-19 did was just to break up the linkages into pieces. However, the governments are trying to say transportation of food is a necessity, and we are allowed to move food. But there were so many red tapes that derailed the movement of food, because we were only looking movement of food as essential services. We were not considering all these other actors as essential services. Next, please. In terms of the input value chain, for those who don't understand agriculture, we have two kinds of value chain. So what we're saying is there is the input side, and then we have the output side. The input side is up to the farmer level. Farmer is the consumer of a seed, of a fertilizer, or either herbicide. So on the input side, we already have issues dealing with climate change. We already have political environment that was not very good and hostile. We had policy environment that had its own challenges. Then we have the support system who are kind of coming up with new breeds, new varieties, we have the financial institution, mechanization, transportation, and extension. And of course, we have the seed producers, suppliers, intermediaries, and farmers. So meaning we have the direct actors, indirect actors, and external influences. By the time COVID-19 got us, we were not already strong enough. It's now that we are only working on our input system for stronger linkages. Next. Food security and livelihoods require a whole system view beyond just production. So we look at the food production, we look at the food system, we look at food consumption, and then we look at the input side. Next. Agriculture majorly depends on face-to-face interactions between the main agricultural actors, connecting farmer, research, education, extension, and other linkages. Agriculture is also time sensitive. It's seasonal dependent. It has timely sensitive trials on farmers' field in terms of technologies, innovation, management practices, training of farmers or pastoralists on teams too. Also time sensitive projects and programs. Next. Researchers, scientists, education, and extension are really struggling. Either they conduct trials, collect data, reach out to their clients, deal with the already weak linkages between the stakeholders, normalize disruption implementation plans for the projects or programs, and protect themselves and their clients, which is very important. And in terms of funding losses, it's not that much of either agricultural research is funded, or if we ask ourselves from the budget that we have, how much goes to the agricultural sector? That is not enough. The pain is most now in terms of emergency measures, we had to move targeting COVID-19 with less support for food nutrition. There was it's a shock. It got us unprepared. We moved into buying all the protective clothing, doing what, but we didn't focus much on the nutrition. Increased operational cost, it's very costly now to even train farmers and do research within the COVID-19 protocols. This was foreseen, but we have no choice, we are doing it, but it's costly. No opportunities for farmers even to interact among themselves. Even in terms of absorption of funds for the agricultural projects, it is derailing, delayed delivery of seeds and other inputs to farmers. Remember, as I indicated, agriculture is time sensitive. You cannot start bringing in inputs later than when the farmers need it for their season. so much tasking to meet the demand for seeds with COVID-19 disruption, not only seeds and even other inputs, because the global value chain have been distorted. For a long time, we depend on trade between nations. Some of raw materials we use here, we source it from another country, and there the supply chain have already been distorted. So all those are issues. Of course, hospitalization and staff losses, deaths, staff productivity, working by shift in labs, and also farmer productivity. So we have the output market disruption in terms of domestic and export. We don't have since the supply chain or the value chain have been broken down, even within the country, exporting becomes a problem. When you want to export, it becomes too expensive. And on another side, in the other country you're exporting to, the demand. First, there is no means to even to export. If there is means, it's very expensive. We know how much it used to go to ship or people to travel at that moment. And of course, the demand in that country. Price escalations, inflation, macro contraction and slowdown, and the issue of food insecurity. Next, please. Priority action and investment by the global community are clearly understood, but progress is uneven. Urgently reaching 30 million people at very high risk, IPC4 and above, to avert starvation. Create fiscal space to give governments room to meet public needs without undermining fiscal sustainability. Ensure open supply chains to connect food producers with demand sources and protect jobs and incomes. Keeps borders open to avoid artificial shortages and gluts that undermine incentives and generate food insecurity. Treat the food and agricultural sector as an emergency sector, focusing on the next season. This is the kind of lifeline of the bulk of the world's hungry poor. Next. How can we go about this? Partnership, building back better together. Digital transformation. The youth are very good in this area. The opportunities that comes in here is kind of to digitize our old systems and try to help how we kind of produce sustainable food. Countries should meet the immediate food needs of their vulnerable populations, boost social protection programs, keep global food trade going, keep the domestic supply chain gears moving, and support smallholder farmers' ability to increase food production. Emphasis to the need for scale appropriate strategies, programs, and plans to build resilience of production supply chains and agribusiness value chains. Focus on targeting priority intervention to the pandemic affected farmers and agro entrepreneurs and strengthen the productive, competitive, and adaptive capacities. Next. As a way forward, the full impact of COVID-19 on food security and agribusiness value chain is long-term and yet to be seen, and especially on the SDG goal number 2. This will be foreseen in the longest time possible on smallholder and commercial farming, households, all value chain actors, and the economy. There is need for comprehensive indicators to capture the impacts so that we can address them, to be on course in achieving SDG goal number 2, to end hunger. Build resilient and sustainable agricultural commodity value chains. Next. Thank you. And we hope to stabilize with time and put happiness on the ailing world population. Thank you.
We can't hear you.
has ably spoken on the COVID-19
I
implications.
cannot hear, please. Is it my side or?
Can I be heard now? I continue. I remove the mask, but they will be getting, but not so clearly. But where they are, they're not. Wait. So what do we have? Can I be heard now? It's not.
Yes, we can hear you.
Yes.
I can hear.
Yes, we can hear you.
You can hear. So we've just been listening to the second presenter, Dr. Mumina Shibia, and she has ably presented on the COVID-19 implications on food and nutrition security. She has highlighted on the issues of income distortions, food security for our planet under pressure, and intensified vulnerabilities and inequalities of global food. And she has also focused on childhood overweight, which is a threat since COVID came in. And she has ably given a recommendation that we treat food and agriculture as emergency. That is the way to go. And therefore, she has ended with a way forward, which has crystallized her presentation. So participants, these have been our two guests, Professor Rogohama and Dr. Mumina Shibia. As we said at the beginning, that you put aside, write in the chat, or you raise your hand so that you are allowed, we unmute you, then you make your comment. We are at the stage of plenary, and we'll take a few minutes so that we get to interact at this point. We will start off with the already recorded questions. Dr. Laura will come over here and present them, and then we'll allow then the others that are on the chat board. Dr. Laura.
Okay, thank you, Professor Mtoto. And thank you, the two presenters who have talked. The first one talked about universal health care, and the second one talked about food and nutrition and security. So far from the charts that we have received, we have a concern from Godfrey Juma, who says that, thank you, Dr. Mina, for the eye-opening presentation on matters of food security. Are there any synergies and trade-offs between different food system outcomes that can be implemented in order to increase resilience to COVID-19 pandemic? That is Juma Godfrey from Kibabii University. And then the second participant, Victor. The second participant, Victor Okello, is asking, is saying that it's a good presentation on universal health care. The WHO recommends the involvement of traditional healers in the provision of UHC. Where are we as a country with this? One of the TM practices, steaming, has really helped in the treatment of COVID. So the first remark goes to, the first question or concern goes to Dr. Mina Guyo, and then the second one goes to Professor Hama Rogo. So presenter goes ahead and says that what was the SDG monitoring app on Play Store? I think this one now goes to Dr. Hamarogo. So we'll have to start with the first one. Professor Hamarogo, are you there?
Yes, I am. Can you hear me?
Yes. Kindly.
Yes, the Kenya's health policy recognizes the role of traditional medicine. The big struggle that we've been having in this country, as in most countries, has been how to regulate it and how to structure it. Because traditional healthcare covers a wide range of things, from the herbal medications to the spiritual. Countries like India and China have done a much better job because they start from their traditional cultures and then adopt modern medicine on top of that. For ours, we dropped our traditional cultures and took modern medicine and now want to rediscover traditional cultures. I have been in a lot of meetings in my younger days as president of the Kenya Medical Association. We've encouraged the proper registration and regulation of traditional medicine, and it hasn't happened well. The only country in the regions, EXA region, East and Southern Africa, that had gone further was South Africa, where traditional medicine is well integrated. But they've also run into problems of regulation. For example, when you go to see traditional herbalist or spiritual healer, and you are working at Kibabii University, and he tells you to go for 1 month of rest, will his prescription be recognized by the university? So where do those things fit in? Now, that does not mean that traditional herbs, particularly, are not used a lot. They are used a lot, and we actually have a mixed health system. And they are used at the community and used at the household level. Taking that to the next level would be an important step. Finally, a lot of our probably potent traditional herbs are being exported out of our country. There are some groups that are doing very, very active exportation of some herbs, plants, and so on. And that has not been properly controlled. And yet that is an area which has major global cost, import, and value. So what I would say is that we have never moved far in this area. We have been too preoccupied with the differentiation and have never completed the regulatory environment. And then, of course, the traditional practitioners themselves, although there has been an attempt to organize them, they've not been organized to the level where they can be useful. With regard to COVID, I must say this, that yes, heat and steam and all those treatments are being used for want of something better. There is nobody who has any evidence that those things have any value. You remember that Tanzania had it, even at Muhimbili Hospital, they had these steam areas, and there is no evidence that they work. But in the absence of anything else, where there is a gap, people always come up with something that at least provides some level of comfort. But we cannot say at this stage that we have anything that is herbal or of a herbal nature that will be effective against COVID. Thank you.
Thank you so much, Prof. Dr. Mumia, there was a concern that you needed your attention kindly. Are you still on?
Yes, I'm still on. Thank you for that. The synergies between these agriculture systems. First, we must appreciate that for a long time, the agricultural system have suffered the individualistic working, like one food system working without kind of connecting or communicating with another level or channel or linkages. So these such linkages are interconnected. And it's unfortunate that the food system faces multiple challenges simultaneously. And the key indicators that we look at, especially when it comes to food system interventions and policies that give rise to synergies and trade-offs that emerge over time due to the dynamic nature and interconnection of this system. One is the climate smart agriculture approach framework that we look at, but also combining with inclusive business modeling. Because when we model it as a business, then everything would be triggered by the incomes people would get from the agricultural food systems. So we hope, looking at the agricultural practices, technologies, and policies inside and outside the climate smart boundaries will result in trade-off across 3 climate smart agricultural goals, where we have increased productivity, increased incomes, and reduction of greenhouse gases. Those 3 goes together for all the value chains and even the agricultural food system. If we are able to implement the 3 concurrently, which is within the climate smart agriculture framework, then that would mean we shall strengthen our food systems. Thank you. So there is something on the SDGs, the app. The app is SDG in action. You can get from your Apple devices. You can download from your Apple devices or the Android devices. It is available. If you don't want to register, you just say you want to explore, and then you'll be kind of getting aware of the 17 goals, the target where we are, what is really coming up, then you'll be able to see globally where we are moving. Thank you.
Thank you so much, Dr. Mina. Participants, this is the progress that we've had since morning of our first virtual international conference, but 5th international conference for Kibabii University. It's ongoing, and we really appreciate your participation since morning up to now. Here we want to have a lunch break of 40 minutes, and then we shall reconvene at 2 p.m. So kindly, members, as you go away, note that the next session will start exactly at 2 p.m. and the chair of session will be Professor Donald Siamba, and the rapporteur will be Mrs. Margaret Wanambisi. Have a good time. Thank you so much.